Welcome to the Study Neuro lecture on the step-by-step management of traumatic spinal cord injury. This session focuses on a structured, practical approach to patient care, from initial assessment to long-term recovery. We will review pre-hospital management, the primary and secondary surveys, and appropriate imaging and diagnostic evaluation, followed by non-operative and operative treatment. The lecture will also cover rehabilitation, complication prevention, prognosis, and injury prevention strategies. By the end of this session, you should be able to apply a systematic approach to early management, select appropriate investigations, outline key treatment options, and understand strategies that optimize recovery and improve patient outcomes. Spinal cord injury refers to damage to the spinal cord that disrupts motor function, sensation, and autonomic control. It is a major global health problem and a leading cause of long-term disability and death, particularly in trauma patients. The injury occurs in two phases. The primary injury happens at the moment of trauma, when mechanical forces directly damage neural tissue. This is followed by the secondary injury, which evolves over hours to days and involves reduced blood flow, swelling, inflammation, and progressive loss of neurons. Importantly, this secondary phase is potentially preventable and is a major target of early treatment. In the acute setting, the most immediate life-threatening complications are aspiration and neurogenic shock, both of which significantly contribute to early mortality. For this reason, outcomes depend heavily on early recognition of spinal cord injury, rapid stabilization of the patient, and coordinated multidisciplinary care aimed at preventing secondary damage and preserving neurological function. Traumatic spinal cord injury most commonly affects young adults, making it a particularly devastating condition because it strikes individuals during their most productive years. Beyond the initial injury, it carries a significant long-term disability burden, often requiring lifelong medical care, rehabilitation, and social support. Anatomically, injuries involve the cervical spine more frequently than other regions, which explains the higher risk of severe neurological impairment. Thoracic and lumbar spinal cord injuries occur less often, but can still result in substantial functional limitations. In terms of cause, road traffic collisions remain the leading contributor, followed by falls, sports-related trauma, and penetrating injuries associated with violence. Pre-hospital care is crucial in limiting secondary spinal cord injury. The priority is to protect the spine while maintaining airway, breathing, and circulation without disrupting alignment. Spinal cord injury should be presumed in all trauma patients, particularly those with altered consciousness, intoxication, spinal pain, or neurological deficits, until proven otherwise. Initial management follows advanced trauma life support principles, with life-threatening issues addressed first under full spinal precautions. Cervical spine protection includes manual inline stabilization, application of a rigid cervical collar, and secure immobilization in a neutral position. Safe handling techniques such as log rolling and use of spine boards or vacuum mattresses help minimize movement and reduce the risk of further injury. In the emergency department, care begins with the fundamentals of trauma management, with special attention to protecting the spine. Securing the airway is always the first priority, but this must be done while keeping the cervical spine stable to avoid worsening the injury. Any airway maneuvers should be gentle and controlled, and patients with suspected high cervical injuries often require early definitive airway management because their ability to breathe can deteriorate rapidly. Once the airway is secure, breathing must be carefully assessed. Reduced chest movement or labored breathing may signal weakness of the muscles responsible for ventilation. Continuous monitoring of oxygen levels is essential, and blood gas analysis can help identify early respiratory compromise. When ventilation is inadequate, timely respiratory support, including mechanical ventilation, is critical to prevent hypoxia and secondary spinal cord damage. Once the patient's airway and breathing are under control, the next step is to ensure their circulation is stable. This means stopping any bleeding and making sure the spinal cord is getting enough blood, because low blood flow can worsen the injury. Fluids are given to support blood volume, and if blood pressure remains low, medications can be used to help raise it. Throughout this process, the heart and blood pressure are carefully monitored to guide ongoing care. With circulation secured, a quick neurological check helps the medical team understand how the spinal cord has been affected. This involves assessing movement, sensation, reflexes, and other functions, which then informs how severe the injury is and what interventions are needed next. At the same time, the patient is fully examined to make sure no other injuries are missed. During the primary survey, it's crucial to quickly identify life-threatening conditions. Airway obstruction from choking, facial trauma, or the tongue must be cleared immediately. Breathing emergencies like tension pneumothorax, open pneumothorax, and flail chest with pulmonary contusion can rapidly compromise ventilation and require urgent intervention. Circulatory threats, including cardiac tamponade and massive hemothorax, can cause shock and low perfusion if not addressed promptly. Rapid recognition and timely management of these conditions during the ABCDE assessment are essential to saving lives. After the patient is stable from the initial assessment, we move on to the secondary survey. This is a careful head-to-toe examination designed to uncover injuries that might not be obvious at first, including hidden bleeding, organ damage, or fractures. It also helps establish a baseline to track changes and guide further care. During the exam, each area of the body is checked systematically. The chest is assessed for broken ribs, abnormal chest wall movement, breath sounds, or any signs of breathing difficulty. The abdomen is examined for tenderness, swelling, or bruising that could indicate internal bleeding. The pelvis is checked for pain, instability, or deformity, since injuries here can cause significant complications. Finally, the arms and legs are carefully evaluated for fractures, swelling, and any signs of nerve or blood vessel problems, including weakness or numbness. This thorough approach ensures that no injury goes unnoticed and allows the care team to respond quickly and appropriately. When assessing a spinal cord injury, it's important to have a standardized way to describe how severe the damage is. That's where the American Spinal Injury Association impairment scale comes in. It looks at both motor function, how strong key muscles are, and sensory function, like the ability to feel light touch or pinprick sensations. In the most severe cases, classified as Asia A, there is no movement or sensation below the level of injury, including the lowest sacral segments. Asia B indicates that sensation is preserved, but there's still no voluntary movement below the injury. When some movement returns, the injury is considered motor incomplete. In Asia C, the majority of muscles below the injury are weak, while in Asia D, at least half of them have useful strength. Asia E describes a situation where motor and sensory functions are essentially normal, either because the injury was minor or because recovery has occurred. Using this scale helps doctors track progress, guide treatment decisions, and give patients a clearer idea of what to expect during recovery. When a patient presents with a suspected spinal injury, X-rays are often the first imaging tool used because they provide a quick assessment of the spine. For the cervical spine, The standard approach includes three views: the anterior-posterior view, which looks from front to back, the lateral view, which shows the spine from the side, and the open mouth odontoid view, which allows visualization of the odontoid process of the second cervical vertebra. In some cases, oblique views may also be obtained to better assess the spaces where the nerves exit the spine. X-rays are very useful for identifying obvious fractures or dislocations, giving the care team immediate information to guide initial management. However, they have limitations. They are less sensitive for detecting ligament injuries or damage to the spinal cord itself. For this reason, X-rays are often followed by more detailed imaging when further evaluation is needed. When evaluating the spine, a computed tomography, or CT scan, is considered the gold standard for assessing bone. It provides a highly detailed view of bony structures, allowing clinicians to detect fractures, dislocations, and alignment abnormalities that might not be visible on a standard X-ray. Beyond diagnosis, CT scans are invaluable for surgical planning, helping surgeons map out the best approach and anticipate potential challenges. Magnetic resonance imaging, or MRI, is the preferred tool when it comes to evaluating the spinal cord and surrounding ligaments. It allows clinicians to see injuries to the cord itself, including swelling or bleeding, and can reveal disruptions in ligaments or herniated discs. Beyond diagnosis, MRI plays a key role in guiding surgical decisions and is essential for understanding a patient's likely recovery and long-term prognosis. In some cases, additional tests are needed to fully assess spinal injuries. CT angiography is used when a vascular injury is suspected, helping detect dissections in the carotid, vertebral, or other major arteries. This information is critical for guiding urgent surgical or vascular interventions. Dynamic flexion extension X-rays of the spine are another tool, particularly useful for uncovering hidden ligament injuries and evaluating cervical instability. When these X-rays aren't feasible, spinal MRI, especially using short tau inversion recovery sequences within 48 to 72 hours, can serve as an alternative. However, these dynamic studies aren't suitable for patients who are uncooperative, obtunded, or have significant subluxation greater than 3.5 millimeters. Laboratory tests are essential for keeping track of a patient's condition after a spinal injury. Blood work can show if there is anemia, infection, or low platelets, while checking electrolytes helps catch imbalances that might cause confusion or seizures. At the same time, coagulation tests let doctors understand both bleeding and clotting risks. Abnormal results like low platelets or a high INR signal potential bleeding problems, whereas elevated markers such as D-dimer can point to a higher risk of blood clots. By combining these insights, clinicians can make safer, more informed decisions about care. When someone suffers a spinal cord injury, the first priority is protecting the spinal cord from further harm. This means careful immobilization, rapid transport to the hospital, and relieving any pressure on the cord as soon as possible. Stabilizing fractures or dislocations also plays a critical role in keeping the cord safe. Once the patient is stabilized, the focus shifts to supporting the body and promoting recovery. Maintaining steady blood pressure helps prevent neurogenic shock, while reducing inflammation and ensuring proper blood flow minimizes further injury. Early neuroprotective strategies, combined with timely rehabilitation, give the best chance for the spinal cord to recover. At the same time, preventing complications like blood clots, infections, and pressure sores is essential for long-term function and quality of life. After a spinal cord injury, maintaining proper blood flow to the cord is critical to prevent further damage. This requires close hemodynamic monitoring with a focus on keeping the mean arterial pressure between 85 and 90 millimeters of mercury, especially during the first week after injury. Continuous monitoring of blood pressure, heart rate, oxygen levels, and cardiac rhythm helps guide treatment decisions in real time. Arterial lines provide precise blood pressure measurements, while central venous pressure can help guide fluid therapy and the use of vasopressors. Fluids are given carefully to correct true volume loss, and medications like norepinephrine or dopamine are used if neurogenic shock develops. Certain drugs, such as phenylephrine, can worsen bradycardia, so they are avoided, while atropine may be needed to manage low heart rate combined with hypotension. In select cases, devices like mast trousers can help reduce venous pooling. Clinicians remain vigilant for complications, including bradycardia, arrhythmias, persistent low blood pressure, or autonomic dysreflexia, since early detection and management are essential to protect the spinal cord and support recovery. When someone sustains a spinal cord injury, breathing can be seriously affected, especially with high cervical injuries. The medical team carefully watches oxygen levels, lung function, and blood gases to catch any early signs that the patient isn't ventilating properly. Injuries around C1 to C5 can weaken or paralyze the diaphragm and chest muscles, so these patients often need mechanical support to breathe. If the airway is intact, supplemental oxygen can help, but doctors stay ready to intervene quickly. Intubation becomes necessary if the patient struggles to breathe, their lung capacity drops, or their consciousness declines, such as with an associated head injury. Managing the airway after a spinal cord injury requires extra care to protect the cervical spine. Movements that extend the neck should be avoided, and a gentle chin lift is preferred over a jaw thrust. In some cases, a nasal tracheal tube may be considered if the patient can still breathe on their own, but all procedures are performed with minimal cervical movement. Ongoing respiratory care is equally important. Regular suctioning and airway clearance help prevent complications like lung collapse or pneumonia. Ventilatory support is provided as needed, with frequent reassessment to adjust care. Special considerations include delaying procedures such as tracheostomy or cricothyrotomy unless absolutely necessary, since early intervention can complicate future cervical spine surgeries. After a spinal cord injury, careful, ongoing care is essential. Patients are often kept flat with their cervical collar in place to protect the spine, while pain is managed with strategies that address both nerve-related and musculoskeletal discomfort. Infections like pneumonia or urinary tract infections are treated promptly, and wound care is closely monitored. Although steroids are generally avoided, they may sometimes be used to reduce inflammation, but only when the benefits outweigh the risks. Mild therapeutic hypothermia can also help limit further damage to the spinal cord. Nutrition is a critical part of recovery. Feeding should start within the first few days, guided by a dietitian, and swallowing is carefully assessed to ensure it's safe. Researchers are exploring several strategies to support nerve regeneration after a spinal cord injury. Medications like riluzole work by blocking sodium channels, offering a protective effect on injured neurons. Minocycline helps reduce inflammation by calming overactive immune cells in the spinal cord. Experimental therapies are also showing promise. AC-105 has been studied for its ability to encourage axonal growth and repair, while SUN-13837, a small molecule, is being investigated for its neuroregenerative properties in preclinical studies. Another agent, cithrin or VX-210, targets specific pathways to enhance axonal regeneration and support recovery after injury. Managing cervical spine injuries often starts with careful traction and reduction. The main goals are to realign fractured or dislocated vertebrae, relieve pressure on the spinal cord and nerve roots, support bone healing, and prevent further injury. In awake patients, early closed reduction using cranial cervical traction can be very effective. However, it should be avoided in patients who have additional injuries higher in the head or neck. If a patient cannot be fully examined or if closed reduction fails, a pre-reduction MRI is recommended to guide safe management. In some cases, such as when a disc is pressing on the cord, an anterior decompression procedure like ACDF may be necessary. Some areas remain debated among specialists, including the ideal timing for reduction and whether a pre-reduction MRI is needed in patients who are fully awake and examinable. These decisions are tailored to each patient to balance safety and recovery. Not every patient with a cervical spine injury is suitable for traction. Certain conditions make it unsafe, such as atlanto-occipital dislocation, specific types of hangman's fracture, or skull defects where pins would be placed. Very young children under 3, elderly patients with fragile bones, or those with movement disorders or additional head and neck injuries are also at higher risk. When traction is appropriate, devices like Gardner-Wells or Crutchfield tongs are commonly used. In some cases, a halo ring may be applied initially and later converted to a halo vest after surgical fusion. Proper pin care is essential to prevent infection, usually involving antiseptic cleaning with povidone iodine and regular monitoring for stability, including careful pin tightening. Surgery isn't always necessary after a spinal cord injury, especially if the spine is stable and the cord isn't under pressure. However, certain situations clearly call for surgical intervention. This includes unstable fractures or ligament injuries, compression of the spinal cord from bone fragments, discs, or hematomas, worsening neurological function, or penetrating injuries that threaten stability or compress the cord. The goals of surgery are threefold: to relieve pressure on the spinal cord, to stabilize the spine with internal fixation or instrumentation, and to restore normal alignment of the vertebrae. Timing is also critical. Early surgery, ideally within the first 24 hours, is associated with better neurological outcomes, while elective decompression can be considered for patients who are improving over a period of 2 to 3 weeks. When conservative measures are not enough, surgical intervention may be required to protect the spinal cord and optimize neurological recovery. The main focus of surgery is decompression, relieving pressure on the cord caused by bone, disc material, or blood. This can be achieved by removing parts of the vertebra from the back of the spine, excising a fractured vertebral body or herniated disc from the front, or evacuating a compressive hematoma in acute settings. In carefully selected patients, minimally invasive techniques may be used to limit tissue disruption while still achieving adequate decompression. Ultimately, the goal of all these surgical approaches is the same: to reduce ongoing spinal cord compression and prevent further neurological deterioration. Once adequate decompression has been achieved, attention turns to stabilizing the spine to prevent further injury and allow healing. Stabilization can be performed from the back of the spine using rods and screws, or from the front using plates or cages to restore support to the anterior column, as commonly done in procedures such as anterior cervical discectomy and fusion. In more complex or unstable injuries, both anterior and posterior approaches may be combined to achieve stronger fixation. These techniques are often accompanied by spinal fusion, which promotes long-term stability and maintains proper alignment. Whenever feasible, performing stabilization early, ideally within the first 24 hours, has been associated with better neurological and functional outcomes. Recovery after spinal cord injury extends well beyond the acute phase and requires a structured, long-term rehabilitation plan. Therapy focuses on strengthening preserved muscles and improving mobility to maximize independence and reduce the risk of complications such as joint stiffness and contractures. Spasticity is addressed through a combination of physical therapy and medications, with targeted treatments used when muscle tightness is focal and function limiting. Rehabilitation also includes attention to sexual health and fertility, providing patients with appropriate counseling to address intimacy and reproductive concerns. Equally important is psychological and social support, which helps patients cope with emotional challenges, manage anxiety or depression, and reintegrate into family and community life while supporting caregivers. Finally, adapting the home environment through wheelchair-accessible layouts and assistive devices plays a key role in enabling safe, independent living over the long term. Preventing complications is a critical part of caring for patients with spinal cord injury and has a major impact on long-term outcomes. Protecting the skin begins with regular repositioning, the use of pressure-relieving surfaces, and consistent daily skincare to reduce the risk of pressure injuries. Thromboembolic events are minimized by encouraging early mobilization when it is safe, alongside appropriate mechanical measures and medications. Respiratory complications are addressed through good pulmonary hygiene, including breathing exercises and incentive spirometry, with early ventilatory support provided when needed. Urinary tract problems are reduced by maintaining clean bladder care practices, using structured catheterization or timed voiding, and closely monitoring for signs of infection. Gastrointestinal complications are prevented through organized bowel programs to avoid constipation or ileus, as well as measures to protect against stress-related ulcers. Ongoing monitoring is also essential to maintain autonomic and metabolic stability, particularly by watching for autonomic dysreflexia and ensuring proper electrolyte and temperature control. Finally, infection prevention relies on minimizing the duration of invasive devices whenever possible and maintaining strict wound and line care throughout the patient's recovery. The prognosis after spinal cord injury depends on several key factors that help guide expectations and long-term planning. The level of injury is especially important, as higher injuries, particularly in the cervical region, are associated with greater functional impairment and a higher risk of medical complications. Neurological status at presentation also plays a major role. Patients with complete injuries tend to have more limited recovery, whereas those with incomplete injuries often retain a greater potential for neurological and functional improvement. Early management significantly influences outcome. Rapid stabilization of blood pressure, proper immobilization, and timely decompression of the spinal cord are all associated with better neurological results. In terms of recovery, incomplete injuries generally show more improvement than complete injuries, with most neurological gains occurring within the first 6 to 9 months after injury. Even beyond this period, continued rehabilitation, therapy, and supportive care remain essential for maximizing independence and long-term quality of life. Prevention remains one of the most effective strategies for reducing the burden of spinal injuries, and it truly is better than cure. In road traffic safety, simple measures such as wearing seatbelts and using vehicles equipped with airbags significantly lower the risk of fatal and severe injuries. Modern vehicle designs, including rollover protection and reinforced side beams, help prevent structural collapse during crashes, while technologies like anti-lock braking systems and collision sensors improve vehicle control and reduce the severity of impacts. Emerging self-driving and artificial intelligence-based systems also show promise in preventing accidents altogether. In sports, prevention focuses on preparation and protection. Structured training and safety programs help reduce injury risk by promoting proper techniques and awareness. The consistent use of helmets and other protective equipment plays a key role in preventing head and spinal injuries, while clear rules and strict enforcement encourage safe play and minimize dangerous behaviors. In summary, managing spinal cord injury successfully requires a team-based approach that follows the patient across every stage of care. This starts with prevention and early recognition, continues through emergency and surgical management, and extends into long-term rehabilitation. In the acute phase, priorities focus on protecting the injured cord, rapid stabilization, preserving adequate blood flow to the spinal cord, and intervening surgically when necessary all help limit permanent damage. At the same time, clinicians must actively guard against secondary injury by preventing low blood pressure, poor oxygenation, and ongoing spinal instability. As the patient moves beyond the initial injury, recovery depends heavily on structured rehabilitation and careful monitoring for complications. Early physical therapy, infection control, and protection of the skin are essential to maintaining health and function. Ultimately, recovery is not one size fits all. Long-term care should be individualized, addressing not only physical recovery, but also psychological well-being and social reintegration, with the goal of maximizing independence and overall quality of life. Thanks for watching. Don't forget to like, share, and subscribe to Study Neuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.